See, there's a little, I think Kathleen put a order there.
So welcome to the second part of our afternoon here, and our apologies for running late. So we're fortunate right now to have Dr. Hyams, who is probably the most knowledgeable person in the province on the illnesses which our society represents, myalgic encephalomyelitis and fibromyalgia. And he is the, owner, director of the Hyams Pain Clinic over in West Vancouver, as well as, now what's your position right now at the CCDP?
So, interim clinic lead.
Interim clinic lead.
Yeah.
At the Complex Chronic Diseases Program. He's also our clinical advisor for the society. He is the head of the Clinical Advisory Committee, of which he is so far the only member, but we do have other people who are knocking at our door wanting to join. We'll let you know who they are.
My team.
And so just before Dr. Hyams starts, we have a little bit of housekeeping. One is, if you haven't filled out the form at the beginning outside, could you please sign up so that we know how many people attended? Rochelle, are you here? I think I've done that right. And if you haven't signed up for Millions Missing, please do sign up, or I'll just badger you till you leave. And I think that's it. There'll be a Q&A after each presentation. So Dr. Hyams will first be speaking about pain and medications, the new guidelines on pain medication. And secondly, he'll be speaking about the new study that came out, the metabolomics study, the groundbreaking study by Dr. Navio. And so there'll be a Q&A after each presentation. We're going to try to rein the time in better for this one, because I know that a lot of you folks are just going to get too tired and you'll peter out. Thank you.
Well, good afternoon, everyone. It's a pleasure being here. Thank you. And I just wanted to thank the board members for, first of all, the invitation to join as medical advisor, and hopefully we can build up a little bit of a team in the years to come to give sound advice to the board members and to pass that on to you folks. So today I have got quite a few slides, and I'm just going to have to see how much time we have to sort of go through this. How much time do we have, Mr. President? An hour?
What time is it?
10 to 3. 10 to 3? We have over an hour. Okay. It depends on how Okay. So it's actually broken up into 3 sections. The first is really a little bit of a struggle for us docs in British Columbia treating fibromyalgia pain with some of the new guidelines that have come on board. So I just wanted to bring that to your attention. So that's been a struggle in our clinic, weaning a lot of patients off medication and witnessing really the difficulty that they've been going through. And it's been a very lengthy experience for us, and having to do long consultations to sort of help these folks come off medication. The other is good news, which I think is to do more with ME, and that is the metabolomics study, which I'm very excited about, and I think everyone is. And lastly, a little bit of vision on our own clinic. We're actually going through a name change, so that's the reason why we've got the 2 new logos up there. It's actually going to become a vision of ours, or hopefully a reality fairly soon, that the clinic will be Hyams Clinic, and then specializing obviously family medicine, chronic fatigue and fibromyalgia. And then we've got great plans to actually start a foundation linking our vision with some of the leaders in the US and abroad. So I'd like to tell you a little bit about that as well if we have time. This is not working. Sorry, we just got a little bit of a stall here.
Do you need any help?
This thing's not advancing. That's on slide 7.
Okay, well maybe we need to restart it. I'll just close
Or we
it down.
can close it down and then just start it up again and everything, maybe.
You
Okay. Take 2. Okay, thank you. So these are just some of the objectives as far as the fibromyalgia information that I'm going to share with you is concerned. So just looking at how we view fibromyalgia as more than just a disease or condition causing hypersensitivity in the brain. The other thing is just looking at the incidence of opioid usage in fibromyalgia in general, the British Columbia statistics on opioid therapy, the new CDC guidelines published which have drastically reduced the morphine equivalent of opioid that we may use for certain chronic pain conditions, and that'll be something just to look at, and also the College of Physicians' viewpoint with regard specifically to migraine, headaches in general, fibromyalgia, and also axial back pain, which means all the way down the spine. How opioids were used in the past to help fibromyalgia patients, I wanted to just touch on that, and then also looking into the future, how we can sort of build on this little hiccup that's happened, because it's more of a public health issue that everyone's aware of, that opioid therapy, I think, has been drastically restricted. Moving on to the objectives for the chronic fatigue, I think also I'd like to just spell out some of the evidence why we think ME is not just a brain sensitization condition. Look at the current neuroimmune research briefly, because we were hoping to get biomarkers discovered in that research, which, as most of you know, the biomarkers that we get through the immune system are more likely to be present in the first 3 years of a condition and not so great thereafter. And then the exciting field of metabolomics, which is really exciting because I think that could capture a series of metabolites forming a biomarker for fibromyalgia and chronic fatigue syndrome, and could also be relevant in the early stages and also late stages of the condition. And so we'll talk a little bit about that as well. And then the future vision, I was hoping just to share a little bit of our vision, my vision with my team, education of physicians, establishment of a CFS-FM research foundation based on my recent 6-month to 9-month experience spending time at Cimarron in the US, and also looking at community-based specialist clinics, how we can sort of tackle that, and inpatient facility for severely affected patients. Should we do the last first, or I'm not sure. Okay. So maybe it will be better for us to take questions at the end, if you don't mind. I think so we can just cover some of the material. So first of all, just looking at fibromyalgia and reviewing the literature, why do we think it's not only a hypersensitization of the brain? There's certainly some evidence to suggest that it is a brain hypersensitization disorder. This graph just merely shows you that you need a certain pain stimulus to register pain in a normal circumstance, and that whole graph shifts much closer to the axis here, which indicates that to the y-axis, which indicates that you need a smaller stimulus to actually produce the same pain intensity in somebody with fibromyalgia or migraine or myofascial pain syndrome. So the medical terms like hyperalgesia and allodynia, which just mean, if you get tickled on your back or on your arm, it doesn't feel pleasant. It's really, really painful for patients. Even my middle daughter, I know she's susceptible. she's very tender, she's sensitive, and every time you give her a squeeze or give her a hug, she finds it a little bit more painful than my other two kids. So I think some of the issues, some of the main breakthrough research looking at how fibromyalgia manifests in the peripheral nervous system is through skin biopsies that they carried out, looking at the density of some of the peripheral nerves. And in approximately 50% of patients with diagnosed fibromyalgia, there's a significant decrease in the density of these little nerves due to damage of the nerves. So now we know it's not just a central nervous system issue, it's also involving, at least in some patients, a peripheral nervous system issue, and that's quite important. So if you, as patients, have lots of pins and needles and numbness and things like that, then I think one has to be more on the lookout for these peripheral neuropathy, small fiber polyneuropathy in some fibromyalgia patients. So let's have a look at the incidence of opioid usage in fibromyalgia. This was a fair-sized study done in 2011, and out of 457 patients, approximately 32% of those patients were on quite strong opioid therapy, many of them on very significant strong opioids such as hydromorphone, methadone, these kind of very fentanyl, which is so frequently heard in the media right now. And the other way of looking at this is how well do they work? And I think this is where I've really been quite surprised in assessing the 100-odd patients that I've had to wean off opioids over the last 3 to 4 months, that the belief system of many of these patients is that this is the panacea for pain control, that it's, treating all my pain and coming off this, I'm not going to be able to function. A meta-analysis of various studies showed approximately, it's right in very small letters there, about 30% efficacy. So if you get 30% out of your opioid, that's about as great as it's going to get. Anything higher than that, it's unlikely that you're going to feel that benefit. So in this slide deck, we'll just discuss a little bit what other interesting treatments are out there that could possibly substitute, the 30% improvement that patients get with opioid therapy. This is well known to most of you from global news and CCTV, and the incidence of deaths, it's frightening, and I think this is what triggered the CDC in the States and also the College of Physicians here in British Columbia to reset guidelines and reset the standards of prescription of opioids. So the new CDC, I'm not going to go through all the guidelines because that'll just take too much time, but what is quite important that for any non-cancer pain, they're recommending only about 50 milligrams of morphine equivalent. We talk about morphine equivalent, that's a unit. So all the other narcotics we compare to the strength of morphine. So that's how we sort of understand, that fentanyl is 100 times stronger than morphine, etc. So 50 milligrams of morphine is next to nothing. In palliative care, doesn't apply. One can go as high as you like with a narcotic to help the patients become more comfortable. We've got to have very good reason to increase an opioid beyond that 50, and if you go over 90, you're treading in dangerous territory because you're out of the guidelines if you're over 90 equivalents morphine, milligrams equivalents. So this is just what is a little bit alarming, and I think all the pain docs, I share their view that this might have been a little bit too strict for pain doctors to take on board, but the College of Physicians and Surgeons made this bold statement in their standard guideline: advise patients that long-term opioid therapy is not indicated to certain medical conditions, including headache disorders, fibromyalgia, and axial low back pain. In my practice, I would say 70% of my patients have one of those conditions. So naturally, my opioid prescriptions have dropped quite significantly. This essentially means if you do prescribe opioids for patients with these conditions, you're in danger of having your license suspended or at least appearing before a review committee to explain yourself. So how has it been effective, opioid therapy in the management of fibromyalgia? Because in my experience, I don't know if I see the more severe fibromyalgia cases, but I've seen patients riddled with pain. And I've always distinguished pain generators, which I regard as inflammatory or mechanical pain. So there might be arthritis present, there may be also injuries from trauma. And the pain generators, naturally, we would always start with an anti-inflammatory or a Tylenol extra strength or something. And then if that doesn't work or the anti-inflammatories are causing too many side effects, then we would go on to the opioid therapy. And the World Health Organization has a scaling system, step 1, step 2, step 3, where step 1 is your codeine or tramadol, step 2, which were great for fibromyalgia, tapentadol, that's Nucynta. It has an opioid effect, and it also has a noradrenaline reuptake inhibitor effect, so that works for neuropathic pain. Buprenorphine in the form of the buprenorphine patch. This type of opioid is probably one of the opioids that least causes hyperalgesia or makes the brain sensitivity worse. That's the difficulty with a lot of the opioids, they can do that. But buprenorphine has been a great drug to keep in mind. Oxycodone, I think that's been long discouraged. And then in some instances, one uses hydromorphone, morphine, or even methadone in severe cases, because that has a opioid effect, and it also has a different receptor effect called the NMDA receptor blockage. So in severe cases, if your pain was sort of 8, 9, 10 out of 10, on average, you might get one of these, such as a Butrans patch. Beautiful, it's applied once a week, and then you may need something to dampen the pain amplification, which is all the neuropathic drugs, and many of us know them. It's the SNRIs like Cymbalta, Prestige, or Effexor. There's the gabapentinoids, which are gabapentin, Lyrica, and topiramate. The tricyclics are very old medications like amitriptyline, nortriptyline. Cannabinoids have moved up to the third line treatment because of their benefits. A lot of patients have gone on to cannabinoid treatment, either through nabilone, which is a synthetic pharmaceutical cannabinoid, but also medical cannabis, which is difficult to afford when you're on disability. And then there are other interesting treatments like cyclobenzaprine that can sometimes happen. That's a central acting muscle relaxant. Low-dose naltrexone. Who's heard of low-dose naltrexone? An exciting treatment. Doesn't work for everyone, but quite an interesting concept. And you can only take that drug if you're off opioid therapy, because it's a opioid antagonist. And then some supplements like alpha-lipoic acid, and there's a Dutch supplement called Pure that helps to reduce inflammation in the brain. So looking to the future and how we control pain in, I think moderate patients with fibromyalgia, you can usually get fairly good control with an integrated model of using one of the neuropathic pain medications at a fairly low dosage, with some good supplements like magnesium and lipoic acid and so on. It's the severe grade patients that can be quite tricky. So now what we're trying to do is divide between pharmacological and non-pharmacological. So pharmacological would be typically the neuropathic pain drugs that I've been talking about, your SNRIs, your gabapentinoids, cannabis, low-dose naltrexone, those type of drugs. There's a recent study that's come out, interestingly, combining Cymbalta and Lyrica, for example, showing much better effects than either one of them on their own. So combination therapy. In the very, 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 very severe patients, IV lidocaine or ketamine may be required to just give a patient a week or two break from their pain. There's ongoing negotiation between the pain docs and the college, I think, to see whether we can bring back things like tramadol and maybe the Butrans patch, which are all below the 50, mostly below the 50 milligram morphine equivalent. And of course, things that aren't anywhere looked at in Canada, which is an ongoing frustration for me, is the neuroimmunological treatments. You know, what's the cause of the pain? And also the neuroendocrine treatments, also involved in that group. Yeah. So neuroimmune treatments, actually low-dose naltrexone also falls into that category. So some people are getting that, but we're working very hard, for example, to look at other things like Ampligen in Canada, and that'll be one of the projects that we're trying to, I've been working very hard on making some grounds there. So that's a classical example that it can improve fatigue in the right individual and reduce pain. The others, rituximab is another one that's in the research phases. We still have access to Immunover here. There are a whole bunch of natural ones as well, Moducare and Epicor, and a lot of immune modulating type of treatments that can be beneficial for patients. So it's trying to find the best one to work for you to treat the inflammatory or pain-inducing cytokines rather than just putting a Band-Aid using an opioid and a pain drug. We're trying to look at the cause. Of course, a lot of patients who have fibromyalgia and chronic fatigue syndrome, we think have diminished hormones, and that was quite interesting, me presenting the data of that at the clinical advisory committee with a whole bunch of endocrinologists. There's small, pretty bad studies going back to the early 90s, you know, talking about adrenal insufficiency, thyroid issues, and so on. But good research is not present, and that's a huge thing. We think we have a lot of patients with fibromyalgia and chronic fatigue syndrome walking around with suboptimal thyroid function, for example, and put on antidepressants, and it's just not looked for, and in fact quite discouraged in an academic institution because it's not evidence-based treatment yet. So non-pharmacological options, you know, I think everyone knows about pacing, that can control your symptoms to a certain degree. Anti-inflammatory diets, nutraceuticals, or natural, more evidence-based products for pain control, such as turmeric, magnesium, omega-3 lipoic acid, wobenzyme, serapeptase. These can all help pain. Trigger more interventional treatment. So patients are being sent left, right, and center for trigger points if they've got associated muscle myofascial pain. If you've got bursitis, you need to try and have your bursas injected to take that inflammation away. If you've got osteoarthritis and fibromyalgia amplifying that, you need to have either the Durolane type injections into the joints or cortisone injections into the joints. And also we're treating the axial spine with facet joint blocks and all these different blocks to try and bring the pain under control because we don't have the opioids available any longer. Meditation, relaxation exercises, and then a lot of patients swear by infrared and TENS and microcurrent stimulation, and a lot of people have been talking about hyperbaric oxygen therapy lately as well. And then, of course, biofeedback therapy as well. Am I going too fast? Is this okay pace? Okay. So we'll shift gears. Anyone want to stand up and stretch, or we just carry on? Okay. We're going to look a little bit at ME, chronic fatigue syndrome now.